Hello, everybody, and welcome to this webinar. I'm very excited that you were able to watch this webinar. It's about a topic that is becoming increasingly more interesting to me as I've had an experience in developing some of the new innovations in treating bedwetting, hopefully to overcome it. My name is Andy Kirsch, and I am the medical director at Georgia Urology. And I'm very happy to be here today to discuss this topic with you. So why are we here? Well, presumably either you or a family member has bedwetting, and as you may not know, you are not alone. There are probably 200 million people in this world that suffer from bedwetting. It affects about 15 to 20% of 5-year-olds, and every year about 15% of children outgrow it. By the time they get to be about 12 or 13, about 3% still have bedwetting, and 1% of the adult population has this problem. What I'm here to do tonight is to discuss ways to empower you with knowledge in a way that's empathetic and provide you with tools to help you manage this problem. It's interesting that a lot of effort goes into managing bedwetting, and parents often spend between $500 and $2,000 each year trying to solve this problem. I'm also very excited to share with you a book that was just released. It's called The Ultimate Bedwetting Survival Guide, and I believe that this guide will really help you to understand bedwetting, to help you manage bedwetting, to show you what's out there in terms of current treatments, how your pediatrician or primary care provider will approach this problem with you, and is really based on years of clinical experience with bedwetting from both myself as a pediatric urologist and my partner and co-author, Ubirajara Barroso Jr., who is in Brazil. So this guide is a compassionate way of approaching this often not discussed topic to provide tools to help you understand and manage your children. So what is bedwetting and how do we define its subtypes? Well, primary bedwetting or primary nocturnal enuresis means that your child has never been dry for a 6-month period. And secondary enuresis means that your child was initially dry, but then at some point after developed wetting. And this is often accompanied by other problems during the day or night. We use the term monosymptomatic, meaning that the only symptom is night wetting, and the term non-monosymptomatic, meaning that there is both day and night wetting, and up to 20% of children who come to my office with night wetting will also admit they have daytime wetting. But I think the overall message that I want to share is that it's really not your fault or your child's fault that they have this problem. So what causes bedwetting? Well, we know that 40% of this is genetic. In that if one parent has bedwetting, their child will have bedwetting 40% of the time. And if both the mother and father have bedwetting, 70% of their offspring will have this problem. But it can also be from other causes, such as a small bladder or even an overactive bladder, one that contracts when the child does not want it to. We also know that bedwetters are very deep sleepers. They're often very hard to wake up. Other causes include some physiologic problems like low ADH hormone levels. ADH is a hormone that's released from the brain, and it allows the kidneys to hold on to water when children are sleeping. And when this hormone is low, this leads to increase in urine output or diuresis, leading to a more full bladder and a greater likelihood that the child will have bedwetting. Other issues that we face in children with bedwetting are daytime problems like constipation being the leading cause. We know that bedwetting can have a significant emotional impact on both the child and their family. Some kids have absolutely no concerns, But most kids really do, and they start to have this concern as they start to get a little bit older, when they can no longer have sleepovers or cannot go to camp like other children because of this problem. There's a lot of shame and anxiety and isolation with bedwetting. And for parents, it creates a lot of stress and fatigue, frustration, a lot of laundry to do. And if you look at how this impacts children, it ranks right up there with divorce and separation in their parents. And the key, as I'll go over, is really to be consistent and supportive of your child. So we know that there are multiple ways of treating bedwetting. And unfortunately, based on some of the largest studies that have ever been done looking at the various treatments, we know that oftentimes the first treatment is really just limiting fluids before children go to sleep, emptying their bladders. We call that behavioral therapy. But the success rate with that is about 18% per year. Now, you should know that by doing nothing, the success is about 15%. So there's not a lot of benefit to limiting fluids, but it is considered to be a mainstay of treatment. Other treatment options include bedwetting alarms, which have about less than 50% success. These often don't wake children up because they're very deep sleepers, as we discussed. And then there's medications like desmopressin or DDAVP, which blocks the release of this hormone and will lead to holding water and therefore decreasing bedwetting. Well, maybe a lot of that is theoretical because the success rate is also less than 50% as a single treatment. And then there are other methods that urologists really don't recommend that often, like bladder training, learning to hold your urine as long as you can. These could often be ineffective, and they're actually risky because a lot of children will suffer secondary problems from holding their urine, like urinary incontinence during the day, and other problems like infection. So we don't typically recommend this treatment option. Now, I think it's important for everybody to know that throughout the world, there are guidelines, and I've listed them here in this table. There's a Canadian guideline, there's an American guideline, there's an international guideline, there's a European guideline, and then there's a United Kingdom guideline. And what I want to point out on this busy slide is that the age of treatment should start between the ages of 5 and 7. And this really involves limiting fluids, the behavioral therapy that we talked about before, emptying your bladder. And if it's not effective within 3 to 6 months of treatment, then first-line, more interventional treatments should be offered. And these include the enuresis alarm or bedwetting alarm, as well as drugs such as DDAVP. So we were very interested in seeing how your pediatrician manages bedwetting. And so we did a study where we sent out a survey to over 100 pediatricians in Georgia that were members of the American Academy of Pediatrics. And we really wanted to know, what was their feelings about starting treatment based on age? What do they feel about bedwetting alarms, time voiding, and behavioral therapy or medications? So the questions that we were concerned about is what is called supportive care, which is really just reinforcing behaviors, so positive reinforcement, behavioral therapy, limiting fluids and emptying the bladder, bedwetting alarms, medications, and when do they refer to a urologist or a nephrologist? So let's look at the youngest age group, age 5 to 7, and your child may fall into this age group. What you need to know is that when we asked about these different treatment methods, you could see that behavioral therapy, which made up about 64%, as well as supportive care was really the mainstay of treatment. There was no other recommendation. And pediatricians at this age typically did not refer to a pediatric specialist. Now let's look at the age 8 to 11. Well, as you can see from this pie graph, about 47%, a little less than half, were still recommending behavioral therapy. About a third recommended bedwetting alarms. And what's important is that before puberty in this age group, 8 to 11, less than 2% would refer to a pediatric specialist. Now let's look at an older group. These are the kids now that have gone through puberty. And you can see that things are now split around the board a little bit more. So the pediatricians are referring about 25% to a specialist. They're using medications about a third of the time. They're using alarms about a quarter of the time. But some are still, up to over 15%, are still recommending behavioral therapy. Now, in the oldest age group we looked at was over 16. And as you can see from this pie graph, about 70% are sending these patients to a specialist for further evaluation. Now, some other questions that we asked the referring doctors are going to be discussed in the following slides. So the first question is, do you think there's a need for new and improved treatments of bedwetting? And as you can see from this pie graph, is that about 54% said yes, definitely, and another third said probably. So most think that the current treatments are not great, and that's one of the reasons why they probably don't use them very typically, despite recommendations made by multiple guidelines. Next question, if you knew that there was a safe and effective non-pharmacologic treatment that could cure primary nocturnal enuresis or bedwetting within a 2 to 3 month period, at what age would you recommend starting the treatment? Now, this is interesting because before, less than 2% recommended anything other than behavioral therapy. Now that if there's a device, for example, that would be effective, you can see that 58% said they would start treating before age 8, and almost 20% said they would start treating at diagnosis at around age 5. 80% would consider early intervention if a better non-pharmacologic option was available. So based on our research into this area, based on these enuresis guidelines, we could say, well, they're really not being followed. And I would say probably for good reason. Treatment is delayed. Less than 2% recommend interventional therapy, and that's bedwetting alarms and medications before the age of 8. And the vast majority would consider early intervention if there were effective non-pharmacologic options, such as devices. So this tells us that there is a need for education, and there's a bigger need for newer and more effective treatments. Okay. So one technology that myself and my partner, Ubira Barroso, have developed is a new technique, a device that will help teach a child what a full bladder feels like. And this process is called neuromodulation, the brain-bladder connection. And if you look at this diagram, our device, which is made by Global Continence, that's our company. If you're interested in more information about this device, you could go to globalcontinence.com and get more information. But basically, the way this device would work is that as soon as a couple of drops would hit a sensor that a child would wear on their skin, it's not an implant, it's something that's wearable, the device would sense the moisture. It would then have a way of stimulating the muscle that will control the loss of urine, that's the urinary sphincter. It'll make it contract, bladder will stop contracting, it'll stop wetting, and then there's an app that will send a message to the parents that this alarm went off. That way, even if the child doesn't wake up, their bed is dry, and a parent could then bring them to the bathroom with a full bladder, and then they could then empty their bladder. And this process called neuromodulation will basically stop bedwetting and teach them what a full bladder feels like, so they learn to sense a full bladder and empty their bladders completely. And this device is currently under FDA review, and we hope to have something within the next year that will really help a lot of children that have been suffering with this problem. And the way that we kind of envision how this device will work is that the child will wear it, as I described. As soon as a drop hits the device, a parent will then go into the child's room, take the device off, bring them to the bathroom, and allow them to empty. And this really gives the child a lot more control, will improve their sense of self, improve their confidence, decrease their anxiety. And we're really hopeful that our clinical trial, which is about to start both in the United States and Brazil, will prove, as our prior studies have, that within 2 months, over 80% of children will be cured of this problem. Another survey that we did through our office at Georgia Urology was really trying to figure out what parents think of all this. So we asked them several questions. And the first question we asked is, are you aware of non-bedwetting therapies such as TENS? And that's transcutaneous electrical nerve stimulation. And you can see that over 90% of parents we asked had really no idea what TENS was. The next question was, does the term electrostimulation raise any concerns for you to use on your child? And you could see that it was pretty equally split between parents that were concerned about this process and those who were not. We then asked if you heard of a bedwetting device that gave excellent results using gentle electrical stimulation to your child's urinary control muscles, would you use it? And even though the parents didn't really understand what a TENS unit was, if it was going to help treat the bedwetting, you can see over 80% of parents are willing to use this device. So I'm really excited about the book. This is a copy. The book is over 100 pages, and it really has a lot of in-depth detail about how you could better manage your child with this problem. So what I want to end with is that this book is really going to be a resource for parents. I think some take-home messages is that bedwetting is extremely common. It's treatable. I want to emphasize that it's not the parent's fault or the child's fault that this is a problem. That you just need to be supportive, that you need to be consistent. This is essential. And I think the Ultimate Bedwetting Survival Guide will have a lot of what I described tonight, but in greater detail. It's written for a parent to understand, so it's not so medical, but it will give a sense of ownership of the problem and give you the tools that you need to give the best possible care to your child and family. So thank you very much, and I wish everybody a great day.